A very good afternoon to everyone, and thank you very much for joining our next NEXUS webinar, ODx Innovations, It's About Time. My name's Jaya Calder from Highlands and Islands Enterprise, and I'm supporting my colleague Andrea, who you'll be hearing from in just a minute. Now, if this is your first time using GoTo, there's just a couple of things that I would like to tell you about to get you involved in the webinar. You'll see a question box. Now, please get involved and put your question in throughout the webinar at any point, and we'll try and deal with all your questions at the end, but don't worry if we don't get round to them, because we'll deal with them after the webinar. And the other thing you'll see, we call it the raised hand icon. It's just a little hand, and if you press on that when it comes to our question time, that lets me know that you would like to come off mute and talk directly to everyone that's on the webinar. And the final thing that I'll just advise everyone is we're going to record today's session. So I would like to pass over to Andrea from Hi. Thank you.
Thanks, Jaya, and thanks for the introduction. Yes, I just wanted to say a quick welcome from Hi. I work in the life sciences team at Hi, but I'm also involved in our city deal projects that are also funded by the ERDF funding and part of the Northern Innovation Hub. So NEXUS is our co-working space on Inverness campus, and this series of webinars is just a way of supporting our co-working space and the community that is building out round about it. So today's session is focused on ODx Innovations, and I just want to introduce our speakers, Ewan Turnside and Giles Hamilton, who I will be handing over to just now to actually take you through their presentation, where they tell you a little bit about who they are and what area they are involved in. Okay, over to you.
Right, I hope you can see the first screen, and I'll pass it to Giles, assuming you can see it, Giles.
Well, welcome everybody. Thank you very much for joining us today. We're delighted to get an opportunity to discuss issues which are relevant to you and your business journeys and share a little bit more about what ODx is up to. I can go to the next slide, please.
Giles, we've got a little bit of background noise that from your end. If is there something that you can mute that we can get a clearer sound?
I think we should just pass to you from here.
Okay, that's fine. We'll put over to you, and thank you very much. Thanks.
We're from ODx, Giles Hamilton and myself, and we're going to talk a little bit about what ODx is doing, how we've got where we are, and a little bit about our business experience, because between the pair of us, we counted it up recently, and we sat or observed on more than 70 commercial boards of companies. But first, we'll kick off with a little bit about ODx. We're an Inverness-based technology scale-up company, and we're developing products for global applications in the clinical diagnostic markets. We moved to Inverness in January 2019, and essentially we've moved into a small office and laboratory in Solasta House, and then moved into bespoke premises on the ground floor of Solasta House. We currently have a core team in Inverness of about 30 staff, and we're growing very, very quickly. And we have a wider team of collaborators and partners, up to almost 100 other personnel. So we're small footprint at the moment, growing quickly, and lots of partnerships with externals. So because of the area of business that we're in, we're looking at antibiotic resistance. So I'm going to give a little introduction on antibiotic resistance and urinary tract infections, which is the target of our first device. Talk a little bit about why it's about time that somebody looked at urinary tract infections and also antimicrobial resistance. And Giles and I will share our wider experience with you about what we've learned in our roles at various companies, and also what makes ODx tick. That being important for both the speed that we have to move and the rate and the ambition that we have for the company. And we'll take questions at the end. So on this slide, what I'm trying to show is a little bit about antibiotic resistance. And if you concentrate on the right-hand blue panel, on that panel, there's a line with little blue dots. Those are all dates when antibiotics were introduced into the marketplace and used clinically. And to the left of that, there is a line with little yellow dots on it. And you can see that the blue dots preceded the yellow dots, and the yellow dots came to accumulate towards the bottom of the table here. And what this shows us is that when we introduce a new antibiotic, it doesn't take too long for the bacteria that are susceptible to the antibiotic to build up resistance to it. And the more antibiotics on the market that come onto the market, the faster the rate of that resistance becoming available. And what this kind of shows is that nature evolves much faster than our ability to develop new antibiotics. The pace of antibiotic resistance is increasing. And it's increasing at such a rate that the WHO consider AMR to be a bigger threat to global mankind, to mankind than global warming or COVID-19, which is our current crisis. And that's why we at ODx think it's critical for us to move very quickly in getting the technology we're developing into worldwide use. There's been a recent report from the CDC in the US about AMR, antimicrobial resistance, and its prevalence. And it's predicted to reach a total of 10 million deaths per year by 2050. So in 30 years' time, there will be 10 million additional deaths per year than there are now, caused because of bacteria that are resistant to antibiotics. Most of those deaths are in communities that have a lower standard of living and a lower income in Africa and Asia, but also currently in countries also where there is fewer regulations about both the prescription and the use of antibiotics. And in many cases, you can buy prescription antibiotics that are only available in Europe on prescription in certain countries without any prescription at all. So for comparative purposes, those 10 million deaths compare to a range of current levels of deaths for diseases that we think are terrible. For instance, for cancer at the present time, it's about 8 million deaths per year. And there's a lot of research and development and clinical interest in cancer. If you look at the level of deaths predicted for AMR, it's going to far exceed that by 2020 and far exceed road traffic accidents, measles, diarrheal disease, a whole load of current diseases. So it's increasing in importance, and therefore, we need to do something about it. And if you look at the current COVID pandemic that we have, currently they're estimated to be about 325,000 deaths due to COVID, and it's shut down most of the world economy for weeks to months, and it will be rattling on for the next year or 2 years until a vaccine or some kind of drug becomes available. The current AMR estimate per year is 700,000 deaths. So in present numbers, it is comparable to what's happening with COVID. And the world's action to mitigate these deaths is less apparent and far less obvious than that for COVID. And therefore, it's a kind of a hidden problem that we need desperately to do something about. So there are about 35 billion antibiotic prescriptions per year, okay? That is 5 days of antibiotics for every man, woman, and child in the world. Of those antibiotics, about 30% of them, the antibiotics are either unnecessary, i.e. the person doesn't have a bacterial disease, or they're inappropriate on the basis that it's probably the wrong antibiotic for the pathogen causing their disease. In addition to that, 70% of the bacteria that are 70% of bacteria are resistant to common antibiotics. And of that 70%, some of those bacteria are resistant to multiple drugs, causing a great deal of problems. I'm sure you've all heard of MRSA, multiple resistant Staphylococcus aureus, which is prevalent in the hospital system and has caused the introduction of a lot of sanitary processes, hand washing, alcohol rubs, very much like COVID in our hospitals. So, what is a urinary tract infection? A urinary tract infection is the presence of pathogenic bacteria anywhere from your lower urinary tract all the way up to your bladder. Okay, it presents in patients with a range of clinical signs, I'll go into those in the next slide. And it's a significant cause of mortality in the elderly. About 3% of GP and other primary care consultations are by people attending a clinic because they believe they have a urinary tract infection. And the result of that is that in the community outside hospitals, about 14% of all antibiotic prescriptions are for urinary tract infections. Now, more problematically, is that a urinary tract infection as a mild infection can progress to a very, very serious infection where the infection moves from the bladder or the urinary tract into the blood, causing urosepsis. And urosepsis causes a large number of hospitalizations, and it's estimated to cause 1.6 million deaths a year. So, and the number of urosepsis patients are increasing. So the burden on the healthcare system due to urinary tract infections moving into this higher clinical level of care is increasing year on year. So it's always interesting when you're looking at a diagnostic test to think about what's the patient experience of the disease. So I'm not going to go through this line by line, but essentially this is a personal experience of one urinary tract infection patient where they felt sick, they had a temperature, so they went and visited their GP. Their GP did a very simple dipstick urine test. I'll talk about that in a little more detail later, to confirm the infection. And the result of that was that the patient was giving an antibiotic. The symptoms and the infection seemed to subside a little bit, but wasn't eradicated. So the patient went back to the GP and got a second course of antibiotics because the symptoms of the UTI came back. Those antibiotics didn't work particularly well, and the patient had recurrent infections, which ended up by them going to see a urologist, having a procedure which caused more trouble, which resulted, in a series of hospital admissions for that patient. That patient went to hospital 24 times with extreme bladder and kidney pain as a consequence of the infection and its progression. The person lost their identity, their job, and all their confidence, apart from all the pain and misery that was caused by the infection. So for most people, this is not the standard course of a urinary tract infection. Most people, they visit the GP, they get given an antibiotic, and if the pathogen isn't resistant to that antibiotic, then it clears the infection. But because of the rise of antibiotic resistance, the number of resistant infections is increasing, and so the first-line antibiotics are working on fewer occasions each time. Now, I'm a pretty old guy, and I graduated with a microbiology degree back in the late 70s. And what struck me after 40 years of coming back into looking at urinary tract infections and how they're diagnosed is that the actual practice in the microbiology lab does not appear to have changed in 40 years. It's very much based on exactly the practices that were adopted when I was an undergraduate student. And all that's changed is the ability to scale up and automate the number of tests rather than the basis of the testing. So when a patient goes to a GP with a urinary tract infection, the GP does an empiric assessment and prescribes an antibiotic based on the symptoms they see and the face-to-face interview that they have with their patient. In some cases, not in all cases, they will use a thing called a urine dipstick, which will give some information about the potential that that person does have a UTI, a urinary tract infection. But it is not an absolute confirmatory test. It is only an indication. So it's entirely empiric, and if the GP thinks that the patient has an infection, they will write a prescription for an antibiotic. If the antibiotic doesn't work and the infection persists, the patient will come back to see the GP a second time. And certainly in the Highlands area, it's only at that second visit that a urine sample is taken and sent to the laboratory. And all the tests to confirm a urinary tract infection are currently laboratory based. So a urine sample has to be taken from the patient, has to be sent to a central lab where it is tested by a variety of techniques. The first test that's done is essentially you have to grow a bacterial culture from the urine sample. So it's plated out on a culture plate, and it's grown at 37 degrees centigrade, and it'll take 18 to 24 hours for the culture plate to show bacterial colonies on it. And so what you're looking for is to count the number of colonies on the plate and to see whether or not it meets a colony forming unit number that is equivalent to indicating that, yes, that's a number of colonies that represent an infection. And in some cases, you can do a basic identification on the plates that are used to identify the type of bacteria that might be causing the infection. So that's the first 24 hours, is purely to isolate some bacteria. Secondly, you want to know what is the right antibiotic that that patient should be giving. So in the laboratory, they do further testing, which is called an antibiotic susceptibility test, an AST. This is where you plate the bacteria out again, and you stick discs on the plate. That's a disc diffusion test. And then you look for the area of the plate. You can see it in the picture here, the area of the plate where the bacteria are cleared, and therefore find out whether the bacteria is resistant or sensitive to a particular bacteria. There are other types of tests, but essentially with the culture to isolate and then the antibiotic susceptibility test, you're looking at up to 48 hours of laboratory testing to confirm a diagnosis. That means with the transport of the culture to the laboratory and the time to take to get the results from the laboratory, that a patient who is receiving an inappropriate or an antibiotic that is not dealing with their infection, it will take up to 3 days for the information to get back to the doctor and the patient that the antibiotic won't work for that infection, by which stage, in a healthy individual, the immune system may have started clearing the UTI, or alternatively, if that's not the case, the patient will come back to be prescribed the correct antibiotic for their infection. So it's about time that there was a better test developed to take out the lag between the empiric diagnosis and the first prescription and the confirmation test that says whether that was the right diagnosis with the right antibiotic, or whether the diagnosis was right but that the antibiotic needs changed. So at ODx, we believe that early diagnosis is definitely going to lead to far better outcomes for the patient and also for the medical system. And what we're developing is essentially a very rapid test, which is taken direct on urine. So there is no culture to isolate an organism, and there's no long 48-hour process in a diagnostic laboratory. All our test is directed to show is whether something is growing or not growing in the urine sample, and secondly, whether or not there is some response of that growth to a particular antibiotic. So if you look on the right-hand panel here to the graph, you'll see that you've got an X and Y axis, and you've got a series of lines that kind of slope up to the right, and a couple of lines with night against them, which are much lower, okay? So what these are is growth curves of bacteria in the presence or absence of an antibiotic over a 60 to 70 minute time frame. So the top lines that are all together that slope nicely upwards, that is a growth control showing that there is something growing in the urine. And then there's also 2 different antibiotics used in those, and they're essentially showing that in the presence of those antibiotics, there's something growing in the urine that is not being affected by those antibiotics. And if you come down and look at the NITE line, which is NITE stands for nitrofurantoin, one of the antibiotics used for urinary tract infections, you can see that the growth is hugely inhibited by the drug. So what we've got here is we've got bacteria in the urine for sure, so it's a UTI. And secondly, we've got 2 drugs which are inactive against that antibiotic. One of those happens to be trimethoprim, sulfamethoxazole, TRS, and that's the first line antibiotic in most of the UK. So in this case, the pathogen is resistant to the antibiotic which would be given first time, but it is sensitive to nitrofurantoin, which is the NITE lines, and the NITE, nitrofurantoin, is the second line antibiotic generally given to patients. So in this patient, the prescription of trimethoprim is unlikely to resolve their infection. But if the test was done at the point where the patient visited the GP and was available at the point of care, instead of prescribing trimethoprim, that GP could prescribe nitrofurantoin, which would clear this infection much faster because the pathogen is sensitive to it. So this is the strength and the power of point-of-care diagnostics. It gets the right antibiotic to the correct patient at the right time. And that's exactly what the test that we're trying to develop. And we're looking to have a point-of-care test to help clinicians in their move from an empiric diagnosis to a much, much more informed diagnosis. So Giles, I'm going to hand over to you.
Ewan, thanks very much for taking us through that. I think it's been very, very exciting to hear from clinicians for a number of years. They're very keen to get quicker answers and also to be able to not prescribe an antibiotic if one's not needed. Very, very hard to tell at times whether what's causing difficulties for a patient requires an antibiotic or does not, and our technology allows us to answer that question. Yes, no to antibiotic, and if not, the right one first time. So it's a very, very big problem. As Ewan's very well put out, 1.6 million people a year dying at the moment, and that's before these additional problems of antibiotic resistance kick in. So big problems need big solutions. What we decided to do is go out and speak to industry around the world, speak to people who were very, very active in this area, and find out, first of all, if they agreed with us, so there was a problem here. The second thing is, given that people were very, very keen to get an answer and see technology could help, is to put a team together that was capable of getting the amount of investment and effort that's required. So we're very, very, very fortunate to get a partnership with Highlands and Islands and Enterprise. We were able to get a very large global technology player on board who's a specialist in this area and put a team together very, very quickly to come up with some of the clinical answers that we need to and develop our technology and get it into market. And our ultimate goal is to try and put a point of care test in Inverness that can help people in the Highlands and elsewhere get fast answers and help this rapid testing that COVID has unfortunately brought to everyone's attention that can make a very, very big difference to healthcare. So as Ewan's pointed out, he and I have been on 70 boards in total, and over that time we've seen the good, the bad and the ugly. We've seen some amazing, wonderful work done, but human nature being what it is, we've also seen quite a few things that with hindsight could have gone better. So in trying to help ODx scale and be a successful company, what we've done is taken a look at the research that's out there that causes companies to fail and causes difficulty. Now, this is sitting online. CB Insights is the source. If you go on Google, you'll be able to find this. And one of our top tips for you in terms of lessons learned is when you're building your business, a great place to start, rather than all these wonderful quiet workbooks, the old adage, you don't learn that much from success, but you can learn a lot from failure. It's worth taking a look at this in more depth and then thinking a bit about your own business and then putting in plans to mitigate against each of these areas. And that's exactly what we've done at ODx. As well as setting out a set of goals to go after year on year and by quarter, we've taken a hard look at the things that cause trouble and put in plans to deal with each of these.
I think this is back to me, Giles. So in a very simple format, from my experience, and I've come from a very technical background as a scientist, it's not technology that is the basis of success. I think it's the 3 M's. It's whether or not there's a market and whether it's big enough for a range of players to play in it, or whether it's right for disruption, or it's been so established that it really needs new technology to take things forward in a completely new way of thinking. So I think lots of companies think they're technology-led when they perhaps should be market-led. Secondly, I'd say that you need a really good, broad management team, and you need a lot of diversity on it. If you're a technology company, you tend to recruit people who are technologists. And actually what you need in a high-tech company is a range of skills dealing with market, with customers, with money, with technology, with development, with quality, with a whole range of things. And that means that you don't want to populate your senior management or your company with a whole range of people with exactly the same backgrounds. But the other side of management is that you need a partnership approach. You need to have not only a wide range of backgrounds, the people have to be able to work together. So there has to be a common mission, and they have to see the goals, and they all have to be ambitious to make it work. You also have to manage a whole range of external partners and collaborations and make sure they work properly and they deliver to your timelines, to the questions that you want answered. So you've got to manage your relationships outside the company. And finally, most companies go bust one way or the other because of cash flow. So money is very, very important. Most of the companies I've been involved in have raised funding from business angels and venture capitalists, and they have a particular view of how a company might work. And that might not be the most appropriate way for the company to function in the longer term, and it may not be the best way even to start a company in many cases. So if you're going to start up a company, think very hard about the future and what kind of money you want and how you use it, but also where you should get it from. And always, as ever, watch the bottom line. You have to watch the cash flow, because I think it's something in the range of 50% of businesses fail because they run out of cash and they have to close their doors. Giles, back to you.
Thanks for that, Ewan. I think the only other thing I'd like to add, we might have my godfather on the line today, who's to blame for getting me into business in the first place. So if so, hello, Robin. Thanks for joining us. I think he and others have taught me that the most important thing really is common sense. It isn't common. It's almost rare in some environments. So I think from our perspective, at the risk of sounding trite, we don't have any great, massive pearl of wisdom for you all to leave with today, other than to encourage people to apply common sense. And in practical terms, I think that means holding the senior executives and the plan accountable. What we do at ODx is every quarter, we pose a couple of questions to our teams. What went well and what could go better? We write those results up, we sit and discuss them, and we took a brave pull a few years ago and we circulate that with our investor as well. It's a very scary thing to do, to put that level of transparency into a company.
Okay, well, I think Giles has exhausted that slide on common sense. So I think that now's a good time to open up to any questions. And then if you leave us a couple of minutes at the end, we've got a parting message to give to people. So I think we're open for questions now.
Okay, thanks. Well, we've had a few questions submitted, but there's still time, so please use your question box. And one of the first questions that's coming in, and it's around about how the local community can help. And that's to Giles and to Ewan.
I think what we're looking for from the community is, we're trying to develop a urinary tract infection test. And one of the key things we need is we need donor urine to put through our test. And we need donor urines of essentially two types. We need from healthy donors, which we use in our labs to check whether we can culture organisms in them and look at the antibiotic profiles of them. But we also need urines from people who are suffering from a UTI, whether it's a one-off or whether it's a recurrent situation. Okay, so we've got ethical approvals in progress to collect urine from a wide range of people. And critical to our development of the test is our ability to access urines. And we clearly have to do multi-center clinical trials in the future, but in the development phase that we're in, we need lots of fresh infected and non-infected urines to do our basic work on.
Okay, thanks. And looking at the next question is, why did you choose Inverness as a location?
We chose Inverness after we looked at a wide range of locations, both in the UK and in Europe and further afield. And actually what we were looking for is a place, firstly, where we could get premises at a reasonable cost, we could recruit the people with the skills that we needed, and where we thought we would be able to get clinical samples in order to help develop our tests. And in some respects, Inverness has delivered all of those things very, very well for us so far. Particularly, we've managed to recruit people both from the area and into the company to work, and we found it a really good place to live and to work, and our employees are happy with the situation. So I think it's been a big win for us locating in Inverness, and we haven't had any problems in working with collaborators. or finding suppliers, or our stakeholders and our investors visiting us in our premises. The modern communications and travel support, working away from very major centres, and in some respects, for us as moving from an early company to a scale-up company, being a little under the radar for a period was quite useful. It allows us to make advances without too many of our competitors being perhaps aware of where we are and what we're doing.
Giles, you should be able to contribute now.
Yeah, I'd just like to echo what Ewan said. We took a very hard look at locations overseas, and Inverness beat off pretty stiff competition, and really delighted with the support we've had. Always keen to get more suspected urine donations, so if people who've got UTIs and they've suffered from the past, we'd love to hear from you, and that's probably the main area we could do with some additional help. But glad to be here, and it's working out well so far. Thanks.
Thank you. Now, the next question that's come in is around about your position on procuring goods and services locally. So what is your position on that local procurement?
Well, thanks for that. Our first preference is to buy local wherever we can. We're keen to make a contribution to the local economy. We're delighted to have a large sum of money from an inward investor. So our practice is always to tender for goods. There are some specialist items that we can only get from overseas, but generally we will always give preference to a local supplier, even if it involves paying a little bit extra. And the other thing is we're very, very keen on making sure we pay our suppliers on terms or indeed earlier, and particularly at the moment where people's cash flows are tight. So being keen to try and make a positive contribution from our spend wherever we can.
Thank you very much. Our next question is, are you intending to hire more people locally?
Yes, absolutely. We're not releasing our target number for this year yet, because obviously the current COVID situation has made a few restrictions on our operations, but we're very, very keen to increase our workforce substantially, and we hope to be able to make an announcement about that in the weeks ahead.
Thank you. Thanks to Adam, who has submitted the comment. I completely agree with the point Giles and Ewan make that market needs must lead for commercial success. So thanks for sharing that comment, Adam. Next question in from Stuart. How does the health sector view your work? Supportive or threatened?
A brilliant question. It usually takes about 10 years to make a change to the standard of care in medicine. Even things like the introduction of a stethoscope was seen as a bad thing because it got between the patient and the doctor. So I think any change is difficult, especially in a service that's under a lot of pressure to practice. So far, I'm delighted to tell you we've had nothing but positive support and relief that something's coming from healthcare professionals. And we think, so far anyway, pleased to tell you, it won't have an impact on jobs. It won't mean if this arrives, other people will lose their jobs, like so many other techniques and new technologies that are coming around the world. So on the balance of what we've seen so far, are positive. And I think mainly because everyone's motivated to do the best for patients, and not giving an antibiotic when it's not needed, or giving the right one first time is something that all healthcare professionals are in favour of. So great question, keeping an eye on it, but it's going well so far, thanks.
Thank you. Thanks for the next question from David, who wants to look around about the rate of growth. So the question is, have you experienced your growth going too fast? And if you have, how did you address this? The rationale for the question will be around skills and the opportunity to develop people to support growth.
You want to start off with that one?
Yes, well, I think growing quickly is always going to be a challenge. But I think within that ODx, we've dealt with that challenge really, really well. Probably much better than other companies I've seen that have tried to grow quickly and therefore stumbled because of that. And I think in some respects, there's a couple of key things there. One is that when we first moved to Inverness, we were a very small team, but we actually very quickly moved into what looked enormous premises. We had about 11 or 12 people in, I think, a 10,000 square feet installation at one point. And we all kind of bounced around in it. But actually, that was getting ready for the future. It got us the premises, got us the space that we needed in order to grow quickly. So we were not constrained by the physical space that we could occupy. So we built in rapid growth. And also, I guess our employment practices is, we'll recruit local, but for key roles and certain jobs, we recruit internationally and we recruit in the UK, and we bring people into Inverness to work there. And I think that, both the premises and the employment protocols that we put in place have allowed us to grow quickly, and we will continue to grow quickly. And secondly, in addition to those things, we have very good relationships with a range of collaborators, and we use consultants externally, we use partnerships and collaborators externally, and we manage them from Inverness. And that's been critical to supporting our rapid growth, in that we can get expert advice without having to fully employ the people who can provide it. So we can get up-to-date expert advice rather by paying for it, rather than by having to employ it and embedding those people in the company and waiting for them to understand everything and therefore participate more fully in the company. So it's a range of measures that have allowed and supported us to grow this quickly.
Thank you. Your presentation and your questions have just sparked a huge enthusiasm of questions. We have piles and we definitely will not be able to get through them, but I'm going to try and get through as many as we can. I'd like to turn to a practical question that's been raised by Karen Thompson. Can you let listeners know how they can become donors to assist this development? How can we actually become donors?
Enroll online at our website. If you head to our ODx Innovations website, you should be able to do it from there. Great question, Karen, and a big shout out for all the help from the campus as well. That's a big reason we're here.
I have so many questions. The choice is phenomenal. So let's just start with the order that we've got in. This looks really promising for UTIs. Is there ambition for tackling other types of infections afterwards? And what scope is there for your technology to be further expanded and diversified?
Do you want to go for that, Ewan?
Okay. Well, yeah. Okay. We focused on UTIs because it was, in some respect, it's a major problem, but it's a lower hanging fruit with regards to the difficulty we thought in addressing it. There are clearly other kind of samples of bacterial infections that get sent into laboratories, and there's a whole range of things that we could do there. I mean, for us, we're very focused on a UTI piece of equipment at the moment for use at the point of care. So in GP practices, in pharmacies, any setting where a patient will get an interview with regards to their health and their UTI status, and where an antibiotic may or may be prescribed. That's our key focus. However, I mean, you could use our current instrument as an antibiotic susceptibility test. And what I mean by that is you could put our machine into a laboratory setting, and where a urine or another sample comes in and a colony is growing on a culture plate, you could pick up that colony, you could put it into our diagnostic, and you could run the growth of that isolate against a whole range of antibiotics. So it has wider applications in that, or we could take it one step back from that and keep it in the point of care. And other things we could look at would be blood, cerebrospinal fluid, sputum, any kind of sample that would come in like that. But in addition, other applications of the technology are wherever there are bacterial tests that check for growth or sterility, we have a very rapid growth test. So if you want something to be sterile, you want the absence of growth. Well, presuming that we had the format where whatever we were checking would grow in our test, we could very quickly check for growth. So there's a whole range of other applications of the basic technology. So we'll be looking at those in due course, but at the moment the focus is on UTIs. But as we are getting more from the discovery and development phase into what a product looks like there, we'll be spending a little bit more time looking at some of the other applications and possibly other types of technology that we could take to market as well.
Thank you. Now we've had maybe about 15 questions just come in all at once. Your engagement is incredible, so thank you. But a lot of the themes are, how close are you to having a proven and tested product and ready for market?
Well, we're going to try and get through the questions quickly with short answers. We can't tell you yet because that's commercially sensitive, but soon.
Okay, next question. What is the blend of employees ratio and where are they from?
Great question. I think roughly half are local and the other half are from other parts of the UK.
Absolutely great. Now, I'm so sorry, but we are out of time for questions. We've got 1 minute left of the webinar to pass over to Andrea, Giles, and to Ewan for just to sum up last minute messages. So I'll come to Giles first.
You heard a very strong message from us. This is a real worry for clinicians around the world. We're getting closer and closer to having something put in their hands. And this is something which we very, very much hope the community in here in Inverness can take a part in and feel very proud they can do something for their fellow citizens across the Highlands and Islands and more broadly. So a big thank you for everyone's helping us so far, and an appeal for more urine samples for people who think they got UTIs. It'd be lovely to hear from you. And I think I'll go to the next slide.
Okay, this is just a take-home message that with the rate of deaths due to antibiotic resistant, in the time we've been talking, there's been about 80 deaths. Okay, in 2050, there'll be more than 1,000 deaths in the same time unless we take some kind of action. So, we might be dealing with COVID at the present time, but keep AMR, antimicrobial resistance, in the back of your mind as to what we can do and how we can use antibiotics better.
And I think that's all we've got. I just want to say a very big thank you to our friends in the NHS Highlands. We wouldn't be able to do anything here without their support, so we're hugely grateful. And we've also been very, very proud and happy to give the help to the NHS locally where we can in the recent crisis. And a big thank you again to Highlands and Islands Enterprise for the support and guidance. I'd like to thank everyone for attending today. Good luck to you and your families coming through this tricky time. And when things lift, we'd hope to see you in our offices in Solicitor House and give you a warm welcome then when we see you. Thank you for your time today.
On behalf of Highlands and Islands Enterprise, thank you very much for an absolutely great presentation. And final thanks to everyone that came into the webinar. You've come in, you've engaged, and that's absolutely hugely appreciated. So thank you very much for your time and have a good day now. Bye-bye.